Shall we wait for a few minutes? Hello. Abhi live nahi karo bhai. Wait for another, just give 5 minutes more and then we start.
हाँ, okay sir, चलेगा. Because 8:30 हो गए, so it will not be live streamed yet. I'm just starting the process.
Hello. Abhi live nahi karo bhai. Wait for another, just 5 minutes more. 5 minutes, just give 5 more minutes more time. Okay.
Okay, sir.
Sir, just give me 5 minutes. I've reached home. I'll just get into the house and re-log into my thing. Sir, Nadeem sir.
Yes, sir.
क्या आप एक थोड़ी देर के लिए लीड कर सकते हैं until I just log in again?
Yeah, no problem.
I'll just park the car and just get into the house and then I'll log in again.
Yeah.
Is that okay with you?
Yeah, no problem.
Okay. Thank you. I'll be there soon.
मुझे ना लगता
Very welcome. Good evening, Dr. Pravin.
Good evening, sir. Good evening.
You ready? All ready?
I'm ready, sir. I'm ready, sir.
Okay, you're the opening batsman today.
You want me to start right away?
No, just I'll just start off with a short introduction, then we start.
Yeah, absolutely.
Yeah. Okay, shall we start?
Yes,
Professor
sir.
Deep?
Yes, sir. Yes. Please go ahead, sir.
Oh, Pradeep is also there. Good, good, good.
Yes, sir. Yes.
From Bangkok.
From Kuala Lumpur, sir.
Kuala Lumpur. Okay, welcome. Welcome. Okay, so shall we start?
Yes,
Yes.
sir. Yes.
Okay. Good evening, friends. We are here today in the third webinar on the pelvic fracture series. The first webinar was on radiology, biomechanics, and classification of the pelvic fractures. At the last webinar, we started with discussion of the lateral compression injuries. There were two webinars on the lateral compression injuries. The first webinar was basically on sacroiliac joint. We discussed the sacroiliac joint dislocation, fracture dislocations.
Crescent fractures.
In the last webinar, we discussed the fixation of the anterior ring fractures, the novel approaches to anterior ring fracture fixations, the Nakatani classification, and crescent fracture classification and fixation. Today is the second of the series of lateral compression injury fracture fixations. And to start off, we have Dr. Pravin Mereddy. He will discuss sacroiliac joint fracture dislocations. Then we have lateral compression injury of the sacrum, spectrum and reduction by Dr. Umesh Meena. Then we have pediatric lateral compression injuries by Dr. Parth Panchal. And then we have a technical note by Borelli approach by Dr. Vijay Sharma, and a technical note on LC2 by Dr. Vivek Trikha, and then recent literature on LC fractures by Dr. Dharmendrakumar. And finally, to summarize, we have Dr. Nirbhay Karandikar. Dr. Nirbhay is on the way and will join us very soon. Okay, so if it's okay with you, Dr. Pravin, we can start.
Yes, sir.
You're the first batsman. Welcome.
Thank you. Thanks so much. Thanks, Nadeem, sir.
Yeah, we can see you.
Yes, sir. I'm just starting off. Yeah.
Okay.
So essentially, it's a continuation of a beautiful talk by Dr. Pranav during the last session. He touched upon mainly the crescent type of injuries. We are touching upon both anterior and posterior fracture dislocations of the sacroiliac joint. So essentially, as we all know, it is important for us to understand the mechanism of injury and how do we classify these and what imaging is the best to diagnose these injuries and recognize and treat them appropriately, and what are the fixation principles. And we'll go through some of the examples, both from the literature and my own experience. Thank you. So next one is where we are looking at is, we all know the strong sacroiliac ligaments, mainly in the posterior sacroiliac ligaments from the sacroiliac joint and the sacrotuberous and the sacrospinous ligaments, and of course the iliolumbar ligament complex. And these provide 60 to 70% of the mechanical stability. And posterior ligaments are very strong and they are attached to the axial skeleton. Sacroiliac joint fracture dislocation involves a significant force which goes through. It can break either the iliac wing. The force goes through the sacroiliac joint, or it can go through the sacrum or the sacral ala, or it can go through the sacroiliac joint itself, just being a pure ligamentous injury. But we are mainly focusing on the crescent type of fracture dislocations today. As discussed before, it can be from a fall from a height or a high velocity injury causing a lateral compression force, which is directed from lateral to medial. And usually in a motor vehicle, it could be a side impact or it could be a fall from the height. And it produces an internal rotation of the hemipelvis and compression of the anterior ring. Essentially, it could be associated with pubic rhumai fractures, ipsilateral sacral compression fracture, or iliac wing fracture or a crescent fracture. And sacroiliac fracture dislocation also could occur. And these are not uniformly stable and they have posterior instability, and that could be occult. So we need to recognize that. AC Day in 2007 from St. George's Healthcare in London, he published his classification on these crescent type of fracture dislocations, and he graded them from 1 to 3. I think this has been clearly mentioned during Pranav's talk as well. And as you can see, the crescent shape is what has given the name over here. And they are starting off from anterior 1/3 to posterior 1/3. So anterior 1/3 of the SI joint, middle 1/3 of the SI joint, or the posterior 1/3 of the SI joint. As they go up, the size of the fragment is larger in type 1 and smaller in type 3. As demonstrated here on the pictures, as you can see, type 1 being the, as I said, anterior 1/3 of the joint. And I think these images are coming in the middle. I'll just minimize that. Sorry. Yeah, I minimize that. So now you can see. And in the type 2, as you can see, it's almost going through the middle third. And in type 3, it is going posterior to the 1/3. And its pictorial picture also is seen here, type 1, 2, 3 on the left-hand side. Suddenly the presentation got stuck. Yeah. So we talk about anterior first, and Dr. Vivek Trikha's publication is nicely written up, and there are 4 cases which I will go through in a minute. But typically, it's extending into the anterior part of the iliac wing and involves the SI joint with disruption of the anterior SI articulation. And it's often associated with the internal rotation deformity or ipsilateral pubic rami fractures. And it may represent an incomplete crescent type of lesion. And what is the clinical relevance? Apparent minimal displacement on AP radiograph may underestimate the posterior instability. I reinforced this even on a previous slide, but CT is essential to define the fracture lines, to look for the sacroiliac articular involvement, and look for safe screw corridors, especially in a dysmorphic type of pelvis. And the posterior SI joint dislocation is again a crescent.
Dr. Pravin.
Yes, sir.
Can I just interrupt you? Your whole slide is not coming. I think you need to make it smaller.
Whole slide is...
The right half is right portion, right 1/3 is getting cut off. 1/3 or less, 1/5 is getting cut off.
How come? I just reduced it now.
But I can see the whole slide, sir. There's no problem.
Full slide now.
Even I can see full slide, sir. I think.
Okay, sorry, there must be something in my thing then. Okay, sorry.
No problem, sir. No problem. So crescent type is the posterior fracture dislocation, which has been very much discussed in the last talk. So radiographs, standard AP inlet outlet, and the CT scan. This would give you where is the sacral fracture, where is the SI joint incongruity, and how is it, and crescent fracture morphology, and posterior iliac fragment size, and the S1 and S2 osseous screw corridors. So associated acetabular or lumbar transverse fractures also can be seen. And when do we operate on these? Most of the dislocations definitely need intervention, but there are certain indications as mentioned here. But the main principle is you want to restore your posterior ring anatomy first and then stabilize the anterior ring when it contributes to residual instability. Surgical goals, I think restoring the alignment and the congruency and the pelvic ring stability. Avoid iatrogenic injury to the L5 nerve root, sacral nerve roots, and superior gluteal vessels, especially while maneuvering in a anteriorly dislocated ones. There are case reports which have shown that there could be an internal or the external iliac artery injury, which I will go through in a minute. And you want to promote early mobilization for these patients after fixation. So close reduction techniques, you could use a joystick maneuver, or you could use a Schoen spin directly in the supraacetabular corridor and then again use it as a joystick. You could use a femoral distractor, or you could use a manual external rotation of the hemipelvis. And you have to confirm in multiple views to restore the SI joint congruity. And we all know the supraacetabular pin trajectory. I think LC2 screw corridor again is going to be covered by Dr. Vivek Trikha. I would not go into the details. And percutaneous fixation, posterior iliac screw fixation, I think again this has been very well covered, but we need to remember you start off in the lateral view with the sacrum, the pin starting off and then checking on inlet, outlet, and confirming that they are safe. And then tips and tricks by Dr. Cyril Moffrey in one of the publications in JCOT. As you can see here, it is very clearly mentioned that how you can reduce by different maneuvers, one going through the LC2 corridor and one through the ilium going towards the sacrum. Once you use a drill tipped guide wire here, you can reduce and then directly pass that and then put a cannulated screw. So that is one of their technique. In their one of their series, as you can see here, it is clearly demonstrating that there is some mal reduction here. So they went in again from the front and started reducing it from the front with the plate and then put percutaneous screws after that. So they do routine CTs over there. When I went for fellowship, I observed that they do routine CTs intraoperatively and postoperatively. So open reduction internal fixation, when is it needed? Well, you have to reduce it whenever it is irreducible, or when there is major articular displacement, or whenever there is large iliac wing fragment requiring direct reduction. And what are the principles? We have direct SI joint reduction and anterior SI plating you could use, or you could use a iliac plating or screw fixation, or you could use a supplemental SI screw fixation. Now we'll go through some of the case examples. But before that, what is the role for anterior fixation? If your posterior ring is stable and the other fractures are not very much displaced and not going to cause mechanical symptoms, we can leave them alone. And this is the Dr. Vivek Trikha's case series, which has been very nicely written almost in 2015, so almost 11 years ago. And you can see in this particular case wherein there is significant anterior dislocation along the SI joint with the fracture, and that has been nicely reduced. And the next one is again grossly comminuted, again an anterior dislocation. It's been well reduced. Third one, again, you can see that it is very well reduced. And this one is again pre-op and post-op. So one of these patients had hemodynamic instability, but otherwise all the others were not having any hemodynamic instability. And move on to the next one. This is another publication from another study. This is a Portuguese paper which looked at fall from a height patient, and he's an electrician, and you can see again a complete dislocation which has been well reduced with a preoperative appropriate planning and execution. This is another 15-year-old boy. This was the one which I was talking about, that there is a vascular injury. You can see that the whole left side external iliac and internal iliac artery has been damaged, and that is the end result, that patient had to go for an amputation because of the vascular injury. And these are some of the examples. You can see 38 years old young lady was hit by a four-wheeler, and she was a pillion rider, and the husband died instantaneously on the spot. And she had multiple injuries. I think you can see that on the plain X-ray, and this was in a pelvic binder, and the CT demonstrated a little unusual here that it is not involving the iliac bone, but it is involving the sacrum. And you can see that, and you can see an incarcerated fragment which we had to fish out before reducing the joint, and that is the final reduction, and that's the 6 weeks and 12 weeks post-op. And third one, the other case is, as you can see, this is kind of a fracture subluxation, almost like an incomplete type of variant, and this has been well reduced. This is the third one. As you can see here, again, on the left side, this needed open reduction from the front, and that's the final result. Thank you. Thanks very much.
Thank you, Dr. Pravin. Are there any questions?
Dr. Pravin, I just have one question. Like you said,
I'll stop sharing. Yeah, tell me.
Always do posterior first, but I feel in my personal, like I don't know, but a lot of cases sometimes anterior disruption is too much, and you start with anterior, try to reduce everything anteriorly, and then go posterior if it is a type 1 crescent fracture. Even in type 2, I think sometimes anterior rami, they are like very much displaced, so reducing them sometimes gives very good reduction of the posterior. That is just one comment I wanted to make.
No,
because
absolutely.
You said always you reduce posterior first, actually. Just comment on that, that's all.
Did I say that? I probably meant posterior ring stability is more important. That's what I meant. I would reduce anteriorly, temporarily stabilize, and then only commit for the fixation. And especially when you're going through the lateral window also, you would go anteriorly and reduce it. Most of the crescent injuries are from the front only first. Absolutely.
Right,
Yeah.
sir. Thank you.
Pravin, the one you were showing about, the one which was done at Cyril Moffery's place, in which you can see there is an asymmetrical, sacroiliac joint. It is kind of closed at the posterior part and open anteriorly, and they've used a supraacetabular pin to kind of reduce it anteriorly and then pass the screw. Is that correct?
Correct. Absolutely.
What comes to my mind is invariably, if you don't do that, you can have, once the posterior, suppose there is a complete disruption of anterior and posterior ligaments, and you don't do this, you will not get a parallel joint, and the compression of the SI joint will probably not happen unless that anterior part is well reduced, isn't it?
Absolutely, absolutely.
So if the posterior part touches the anterior one, there is no way you are going to be able to reduce it only with the screw. The screw can be passed. The screw is not a reduction tool; it's a fixation tool, isn't it?
Absolutely. I mean, you have to reduce, like any intra-articular fracture, you want to reduce it first, then only put the guide wire, then only pass the screw.
In fact, even when we are putting in the SI joint screw, unless the SI is reduced, putting in the screw, you're just probably mal-reducing the fracture unless you're...
And I think it is very, very important for these joints itself, as you can show in Dr. Cyril Murphy's paper itself, that they themselves could not believe that so much of malreduction was there. So, and that is classic of especially a significant injuries going through the SI joint and, the crescent type of injuries, because in one view, it would look perfectly reduced, and the rotation, translation, vertical orientation. So it could be in any of these planes that it could, be mal-reduced. So that's why multiple views and being patient, I think that should help. Yeah.
After coming back, have you, I mean, this is, most of my patients don't really, finance is an issue. And so I have not really got a CT scan done post-op, but after coming back from my fellowship, is that what you've changed about your practice?
No, I haven't actually. On the similar note that getting a CT done for every patient is probably going to be one, expensive, two, radiation, and to convince a patient in Indian scenario for a repeat CT, it's not easy. It's not easy, especially in a corporate hospital. Yeah.
Meena Saab, in a place where money is not an issue, like for example a government institute, or in fact even Dharmendra should also be asked this question, where money is not an issue, especially in a sarkari institutional setting, is it easy to do a CT scan? Do you do it frequently, or you don't really bother about it? What's your take? Umesh sir, are you there? Aditya, are you there?
Actually, I'm also in government institution. I can tell
Yes, yes,
Nirbhay,
sir.
I think
Sir, are
if
you
you
doing
have
it in
most of
AIMS, sir?
no, not in all cases. Either it is a part of PG thesis, then obviously you get to look at the reduction. Otherwise, if you have some doubt of any malreduction, or if there is any confusion, or if suppose a T-shaped fracture you have fixed on one side and you are not very sure you want to go other side or not. So there are fixed indication, not in all the cases, sir. Not in all the cases.
My point is, sir, if we accept and agree that your results of your fracture pelvises are usually dependent on neurological recovery and genitourinary recovery, and not so much on the bony reconstruction at all per se. Praveen, this is what we were taught in GRAS, correct?
Yes.
So in that case, uh, is doing a CT and refixing, is it an overkill or should that be encouraged? What is your personal opinion on that?
If I have all the facilities and feasibilities and nobody, what do you call,
No
disrupting
constraints.
to get a CT done, I would get one done. Only to improve and give the best to the patient. But
I
with
mean, would you
the
accept a slight malreduction or would you revise?
in a SI joint,
Yes, yes.
crescent type of injury, probably I would accept a slight malreduction, because going back and doing an extensive surgery can be more detrimental and higher risk of infection. And it is a joint which would probably tolerate, compared to a hip or any other joint, a little more. It's not a proper articular type of incongruity what we are worried about. Here, it will develop some arthritis and dysfunction anyway. So I would accept slight.
Sir,
But
do you have
given
any
a
other?
chance, I would achieve as perfect reduction as possible whenever it is possible. Yeah.
Umesh bhai, do you have anything to add to this?
He's muted.
Umesh bhai, you'll have to unmute yourself. You'll have to unmute yourself.
He's muted, I think. Yeah.
Umesh, can you hear us? I don't think. Umesh bhai, can you unmute yourself, please?
Unmute. I don't know if he is able to hear.
What I
Yeah, Parth, go ahead. Shoot.
what I feel in our situation, if we find on table it's reduced well in all the views, and getting a post-op surgery would be a difficult task for a patient in our country. But sometimes the patient has some symptomatic pain, like sometimes you have some severe radicular pain post-surgery, which was not pre-op. So definitely I will go for CT
Yes, I
scan in
mean,
such cases. Yeah.
so CT would be done if there is neurological deterioration
Absolutely,
post-operatively.
yes. Deterioration, and it is sudden onset of neurological pain. That's the only indication what I feel that I would go for re-CT. Otherwise, if all radiological parameters are satisfying on table and even post X-ray, so I will accept it. And otherwise to open and make it more detrimental, what Pravin sir has said.
Umesh bhai, have you managed to unmute yourself?
We can go ahead with next talk.
Any comments?
Umesh bhai, you can unmute yourself and we can. Thanks, Pravin. Thanks for your wonderful talk.
Thank you. Thank you.
I think we
I
can
will
just go on.
I'll mute myself 1 second.
Yes, yes, yes. Pradeep, it's good to have you back. Umesh sir is going to talk to us on lateral compression injury, the sacrum spectrum reduction, whether and how, and fixation. All yours, Umesh bhai. उमेश, at the bottom of the सबसे नीचे में जाके आप unmute कर लीजिए अपने आप को.
He's unmute, I think.
Go to the bottom of the screen.
He's already
He is one,
unmuted.
but I can't hear him. But we can't hear him, no?
I think someone calls him and then tell maybe there's some.
We can move to
I'll
next
do
talk.
I'll call him up.
We'll
We
move on
can
to
go on
next
to the
talk.
next one.
We'll move on to next talk and then we can take this talk later.
Who is next, Pradeep?
Parth. Parth is next.
Parth wanted to go on last.
Because Pradeep, I'm just traveling.
Yes.
Within 10
So
minutes I will resume your network. आ जाएगा.
we can get Dr. Vijay Sharma's talk then.
Yes, yes, yes. Sharma sahab, go ahead.
Yes, sir. Yes, sir. Am I audible and visible both?
Yes, sir.
Nirbhay?
Both, sir.
Both. Okay. Then
Both,
it's
sir.
yeah. So I will be talking about a Borelli approach. And after this talk was given to me day before yesterday, then I started reading about Borelli. It was very interesting to read about him. He's working in Florida, and he did his training in Tampa, and then he worked with David Helfet, where he and Cowell, and where he wrote this article, which became quite popular article. So basically, all of us know that no one wants to go posterior, no one wants to do patient prone because most of the soft tissue injuries are there. And even the best of literature results of midline posterior approach, where we sort of retract multifidus and gluteus maximus. So result to 18 to 27% complication rates are there in almost all the literature. So that's why Borelli came out with the in all crescent fracture dislocations, he came out with a very simpler approach, there was less soft tissue dissection, and number of infections and number of soft tissue issues and vascularity of the area was quite good. So he had very good results in his 22 cases which they published in 1996. So indications of posterior approach, obviously all lumbopelvic fixations, all sacral fractures, delayed presenting SI joint dislocations, and crescent fractures, some specific subtype of, all of us know that type 2 crescent fractures, they are problems. Type 1 fractures, they are managed from anterior approach. Type 3 fractures, they are treated as more or less SI joint disruptions. So the problem remains with the type 2 fractures. And the people like Parth, Pradeep, I think most of people who are doing a lot of LC2 injuries, they manage even type 2 crescent fractures, day type 2 fractures with percutaneous fixation, looking at all the scans. And if they are able to put screws from the displaced fragment to the constant fragment, they still don't make patient prone. So Borelli approach was a prone approach done in the prone position. So if we look at crescent fracture, I think it has been covered. So it's a major disruption. So constant fragment is a fragment with crescent, and rest everything is unstable. So it is internal rotational instability, because sacrotuberous ligaments and sacrospinous ligaments are not injured. So there is no vertical instability, and patients, they usually have good external rotation like stability. So only internal rotational instability is there. So mechanism of injury, it is already, I think, discussed. The functional classification by day, it is discussed. And the problem is type 2. Why I'm again opening this? Type 2 is where if you put a percutaneous screw, then the screws are likely to come in the fracture line. And if you open it anteriorly, you're not able to look at that crescent fragment. So type 2 fractures, they are difficult fractures. And this is the only crescent fracture where surgeons, they plan posterior Borelli approach. So it is very clear. Type 1 is anterior, type 2 is a problem, and type 3 is a small fragment where most of the fracture dislocations are treated as sacroiliac joint dislocations. So we all know that constant fragment is the fragment which is with the sacrum. Rest everything is unstable. So we have to connect the displaced fragment with the constant fragment with the best possible construct. So if you look at the approach, it is done in the prone position. So before the start of surgery, look at all the views. Just rotate the C-arm and inlet, outlet, lateral, and AP view, so that there is no obstruction when the surgery starts. So this is from our dissection lab. I was not able to retrieve the video in such short time, but it is slightly over the crest or slightly lateral to the crest. Depending if you are doing it for a type 1 sacral fracture, you can even go slightly medial to the crest. And it's a straight incision from PSIS to up to the greater sciatic notch. You can curve it proximally to the iliac crest if the fracture needs that. So if you look at the deeper dissection, gluteus maximus, we know that there's a very good video by Dr. Vivek also. I think the gluteus maximus fascia, it is like it attaches on the spinous process. And obviously there is both the fascia over the erector spinae as well as gluteus maximus. So if you cut it in between, then you denervate that area. But this approach, the approach Borelli used to do, he used to give sharp incision over the crest, posterior superior iliac spine, posterior inferior iliac spine over the crest, and then he used to sort of subperiosteally elevate the gluteus maximus from the outer end till the time fracture, that the type 2 crescent was totally exposed. And if there was associated, he had to go medial, then erector spinae can be erased from the medial side. So this is elevation of gluteus maximus, and we can see distally gluteus maximus as it is attached with the sacrotuberous ligament, strong ligaments, and the fascia attaches towards the midline. So we should know all this anatomy, and this is cut, and this is retracted. So if erector spine is also it needs to be some sort of lumbopelvic or some sort of big fixation needs to be done. Then multifidus can also be erased from the sacrum, and it can be sort of tongue type. It can be lifted up or it can be retracted medially. So this kind of exposure can be done very nicely. So this is erector spinae, and this is access to the inner pelvis. So you can put your finger and you can reduce the anterior part of the SI joint also. You can at least check the reduction. Sometimes what happens, your crest looks reduced, but when you put a finger through the notch in the anterior part of the SI joint, you find it is totally open. So because you need reduction of the SI joint also. So there are clamp placements you can with the spinous process, and towards the outer side of the ilium, you can compress it to reduce the SI joint, or you can put eccentric retractors anterior to the outer side so that SI joint is nicely reduced. So this is how the retractors can be placed from the posterior side. You can see nice retraction placement, right? Nice reduction, and then you can put wires from the crescent fragment to the constant fragment after checking the reduction in all the three views. And this is how reduction. And then just a plate should not be applied, because if just the plate is applied, then distally it is quite unstable. So most of the times we put either if the fracture line is visible, then we can put a screw from the constant fragment to the displaced fragment. Few people can apply another plate also at 90 degrees, the way we apply plate for anterior SI joint. Otherwise, because fracture line is now exposed, then you can directly under vision put SI joint screw, just taking care of the thing that it should not enter the fracture site. So this kind of fixation is very common even in prone position. After fixing the crescent fragment, then you see that you have space for the screw fixation, and then you can put the screw. So this is how the Borelli, and this is something very important, because you have to sort of put a screw from the displaced fragment to the sacrum, because sacrum along with the crescent fragment is a constant fragment. So you have to put fixation from displaced fragment to the constant fragment. Now, like this case was the patient living in India from Nepal. RTA brought to JPNATC, pelvic compression test was positive, binder was applied. So this is a typical case where in few views we were like thinking that we can go anterior, and a few pictures we could see that we can do percutaneous. But if you see VRT image, you can see if you try percutaneous fixation in this case, there's a high likelihood of that screws are going to go in the joint. I think I discussed with Pradeep also, then he opens it and slightly and applies a 3-hole plate so that the proximal portion of the plate goes in the crescent position, and then SI joint is put through the third screw. So if you see closely, it is a typical type 2 where if you put a screw, screws are likely to go in the joint, go in the fracture fragment. And this is a good indication of going from the Borelli approach. So type 2, like we have to see the posterior approach. So it was patient was put in prone position, fracture was exposed, and so this was the incision. Like total, this was the incision to the patient. And same way, I think, but I have already shown you the dissected images. So this way it was exposed, and proximal part was reduced, a plate was applied, and then two screws were put from constant fragment to the displaced fragment. And then we had some space to put a wire. It is a dysmorphic, so the screw is put in the S2 screw. So this is 6 weeks follow-up of the patient, and this is 6 months follow-up of the patient. And the patient is doing very good. There's no pain, no problem. Like with experience, sometimes we switch a Borelli approach and we try to do everything anterior. Like this case, we tried to, there is a severe displacement anteriorly. So we started off by doing anterior fixation first. We applied a plate on the anterior. Then we found out on all the views that we had some space to put SI joint screws. Then this kind of fixation was done, and it went on to unite. So to conclude, the problem is only type 2 crescent fractures where Borelli, Dr. Borelli comes into picture. If you feel that screws are going to cross the fracture or they are going to break into the fracture, then that is the best time that, and you are not able to do anterior like in type 1 crescent fractures. That is the only indication of making the patient prone and doing anatomic reduction of that constant fragment with the displaced fragments. And I am telling you, when you open up the when you superiorly retract the gluteus maximus by this approach, you see the fracture, you fix it, and then you have a lot of place to put a even SI joint screw from the posterior approach. Type 3 crescent fractures, they are managed by percutaneous iliosacral screws. So take home is, for type 2 fractures, we have to plan whether we want to, we are able to put percutaneous screws, or we have to do a prone position. This approach is a very straightforward approach. Almost it's like taking the blood, the bone graft from the posterior approach, which we used to do. So it's a simple approach, a periosteal elevation. to avoid necrosis, wound dehiscence, and then you can combine multiple implants and give stability to the posterior side from this approach. Thank you.
Thank you, Sharmaji. That's a wonderful presentation. फरूकी साहब, आप कुछ बोलना चाहेंगे? Faruqui Saab, are you there?
Actually, sir, Nirbhay, there was one article, current article, where 70% of the doctors, surgeons, they did type 2 crescent fracture by percutaneous fixation. So posterior approaches are becoming less and less with increased understanding of these fractures, and then calculations that we are able to fix everything from anterior side, and we don't make patient prone. So, but still, it is useful. It is a useful approach.
Nadeem साहब, आप कुछ बोलना चाहेंगे?
No, I think it is wonderful to know that this approach is there. But basically,
Yes,
I think we rarely need this approach. Most of the
yes.
time, we can manage without doing this approach, like Dr. Vijay has already pointed out. So I think it's good to know in a rare case, if needed, you can do this. But I think most of us can manage without going to this approach. So I think it's good. I think we carry on with the.
Sir, I have a couple of things. So I have been using this approach quite frequently, especially for fixation of VS kind of injuries to the pelvis, in which you find typically that the hemipelvis has moved posteriorly. So when you put the patient into the prone position, I find that the fracture reduces quite remarkably well. A large number of these patients sometimes have, I think I've been seeing a lot of these sacral dysmorphism patients. And by putting them into the prone position, I find putting the S2 screw also becomes easier. The trajectory is so much easier. And I have also been doing a lot of these posterior ilioileal platings for these kind of fractures, for sacral fractures and stuff. This is a very safe approach. I have not had a single problem in any of the. I've done about.
But sir, you do like paramedian incisions both the sides, or you go midline?
Yes, paramedian
Paramedian
incision both
yeah.
sides along the
Actually,
iliac crest,
sir,
just like.
Nirbhay, there are absolute indications of going prone, like sacral fractures. Delayed presentation is one.
Yes.
Like I think there is going to be a lot of discussion if you say vertical, and if you say that reduction is going to be difficult in prone, because if it does not come, it will be very difficult because you cannot manipulate the patient in any way. In supine
I
position,
find.
rather in fresh fracture, it will be very easy because you flex the hip to 45 degree, you pull it, because all the vectors are all the vectors can be taken care of in a supine position much better. In a badly displaced SI joint disruption, prone can be sometimes very difficult. That is what my understanding.
I have been doing them for some time now, and I find quite remarkably that the reduction is very easy. I've not had too much trouble. Done a few of them. I've done about, I think, 14, 15 of them.
Right, sir.
Not had too much. And suddenly the iliosacral screw also becomes very easy in the prone. We don't need to put, normally we put a bump under the buttock and then the pelvis keeps on twisting and turning.
Right,
Not
sir.
had too much trouble with this. And I found that the gravity assists the reduction and a little longitudinal traction, and the reduction is pretty much easy. But of course, Pradeep will have something to say. Pradeep?
With the
Actually, I think.
Sorry. With the
Yes.
ilioileal plate, you have this. If you with this incision, you have
Yeah.
problem with skin problems.
I've done I've done quite a bit of them, sir, because I just wanted to try it out on some of my patients. I've done it on about 16, 17 of my patients, and quite remarkably, sir, I've not had a single patient with a problem, because there's a way to do this. In fact, I have experimented. I have moved from a recon plate to a thicker plate also, and no problem at all, sir.
I think one place which I find a approach to be very much indicated is little bit delayed patient when we want to apply the Farabuff clamp and get the reduction. That is number one, and number two is that sometimes with the crescent we get slight opening of the posterior part of the SI joint also, especially if there is comminution. Then
Yes.
putting the SI plate,
It is very easy to reduce.
plate across the crescent and screw becomes mandatory. So in that case, I think this approach is much more needed. I think we must have it under our armamentarium.
I'd just like to extend my welcome to Dr. Trikha. I see he's online as well. Thank you for joining us, Dr. Trikha.
Thank you. Thank you, sir.
Thank you, sir. Thank
Nadeem, sir, shall we go ahead?
Yeah, please.
It's
all yours.
I think Umesh sir is yet to join
No,
us,
I
but
saw
he's
him.
having
He's
some
there, I
issues.
think. He's there.
I just got a message from him saying that he's trying to join, but there's some issues. So shall
Dr.
we
Parth
ask
is
Dr.
also
Trikha
there.
to complete his talk? Parth, are you free to join in, or do you
Sir,
want some
I
more
am
time?
just connecting. Just give me 2 minutes, sir. I think Umesh sir can complete his work.
I can do that.
So Trikha sir, why don't you take your talk, sir, while
Sure.
Umesh is also trying to get online, and so is Parth.
Right. So can you see the slides, please?
Yes, sir.
Okay. So thank you. And I was supposed to be speaking on the technique for LC2 fixation from the interior side. So I shall be covering partly the injury pattern, indications and setup, technique with imaging, which is required, and then some 1 or 2 slides on pitfalls which we need to avoid. Remember that the LC2 screw is basically meant for the LC fractures as such, which were in pelvis. But most of it, we nowadays are using it for acetabular fractures. And just a minute. Able to see my slides? Can you see my slides?
Yes, we can see your slides, sir.
Actually, I cannot see my slides, so that's. I'll just
No,
stop
wait.
sharing. I just give me a minute, and I'll just. What happened? There you can't see.
So you are ready? Some problem?
Should I do it now, or somebody else
Yeah,
is doing it?
no, you
Just go ahead, sir. Just go ahead.
Please go ahead.
Okay, fine. So you can see my slides, right?
We can see you now.
Right. So as I was
We
saying,
can
the
see,
injury
sir.
pattern, as I was saying, the injury pattern involves the pelvic injuries, which are lateral compression injuries. What exactly the LC2 screw is made for is when there is a vertical fracture of the iliac wing, it needs to compress both the segments from forward and backwards. And that's what it does by putting in a compression screw. The fracture patterns, however, where we use this screw does not belong purely to the pelvic injuries. It also goes for acetabular injuries, for the ACPHTs and the ABCs. So these are the fracture patterns. Maybe you can say along with LC fractures, which were the crescent fractures, would have been just discussed by Professor Vijay Sharma, and the various methods by which you can do it from the backside. But these are the columns and the acetabular fractures also, along with the LC crescent fractures, which you can fix by the LC2 screw when it is more anterior than posterior. And hence, most of the fractures, when you are going for supine fixation, then you can go along and fix this LC2 screw. This LC2 screw insertion can be done in an open way when you are doing it, as I said, for an ilioacetabular fracture by an anterior approach of iliofemoral or by ilioinguinal. Or else you can also fix it by doing percutaneous reductions by shank spins in the iliac crest and then putting it percutaneously. Remember that before fixing the LC2, it is reduction which is most important. That's the place from where we put in the LC2 screw. So let's first understand, for the benefit of the people who will be putting it for the first time, how and what imagings are required for this screw. You need to have an iliac oblique view by which you see the entire ilium. In a profile, you can see the entire ilium. So these are the views. In an image intensifier, when you look at it, this is the view which you are looking for, which is the iliac oblique view from the front. And the artery forceps which you look at is at the anterior inferior iliac spine. Remember that, because we will be using it for our fixations and when we rely on the C-arm images for the fixation of this LC2 screw. The second view which you need to look for is the combined obturator oblique inlet view, which is you put your image towards the inlet and then shift it towards your own self, which is the same position as the patient of the fractured place, which is the obturator view. And around that view, you are going to get this view, which is also known as through the wings view, where you will find the outer border and the inner border of your iliac blade. That's how it looks like in an image intensifier. And you can see that there is a corridor which you can see from the SI joint. If you see the inner part of the pelvis, as well as the outer lateral border of the ilium and the false pelvis also, which you can see. And hence, this is known as the combined obturator inlet view. And then, can somebody mute
Parth,
it, please?
can you switch off? Yeah, Parth,
Yeah.
can you just mute yourself,
Yeah.
because it is.
So, and then it is also known as through the wings view, rather, in which you are seeing both the wings or the wing of your iliac crest from the profile, both the outer wall and the inner wall. Then the third view which you need to look for is the combined obturator outlet view, which is COOO view, which is known as where you put your image for an outlet and also an obturator view. And in this, you look at this teardrop. This teardrop again is the osseous corridor. This is the supraacetabular corridor in which you want to have a look and put in your pin. You can put in the, as you see, here is a pedicular screw for infix, spinopelvic fixation, which would have been discussed, or posterior fixation. The same view is required. You can put in a screw, you can put in a Shan's pin, you can put in a pedicular screw. So this triangular teardrop or the TP view, which is there, in this teardrop is the portion which is the osseous corridor, and your screw should be in between that. And finally, you look at the lateral view. The lateral view is because if you are putting in a screw, which is going from anterior inferior iliac spine, which is the LC2 corridor, from anterior inferior iliac spine towards the posterior spine, you need to know whether you are coming out from the posterior side or not. And then you take the lateral view. This lateral view is going to tell you, if you mark this corridor, whether you are going out of it or you are remaining inside the bony corridor. So remember these four views which I told you: the iliac view, the inlet obturator view, the outlet obturator view, and the lateral view. These are the four views which you will look for in LC2 screw. The entry point, as I said, is same as supraacetabular fixator or infix in the percutaneous insertion. So if you are putting it in a percutaneous way, you take the tip of ASIS, put in a vertical line from there down for 5 centimeters, and then go medially from that tip, lower 5 centimeters medially towards 3 centimeters. This is the rough estimate where your anterior inferior iliac spine will lie. You can give an incision, and then you can try to feel open up between the sartorius and the tensor fascia, and then feel the anterior inferior iliac spine under image intensifier. This is the place where you want to insert and get your entry point. This is the screw which you want to put, and we will see subsequently, and the views which I told you were the previous views. With this background, now let's see how do we exactly do the sequencing of this technique. So as I said, these are the three views which you require: the obturator outlet view, the iliac view, and the inlet obturator view. So these are the three views based on which you will put in your entry point right in the center of the teardrop in the obturator outlet. which is at the prominence of the anterior inferior iliac spine in the iliac view. Remember, the distance from the joint up should be at least 2 centimeters because the capsule inserts till around 1 to 1.5 centimeters above the joint. Hence, the screw should be above it. So roughly 2 centimeters will be adequate. And then this through the wing view in which you can see the iliac wing, and your screw should be, or the guide pin, whichever you are doing, should be lying in between the two parallel tables, and that's why you can put in the screw. Subsequently, if you are using a guide pin, guide wire, or a K-wire, over that you can put in your cannulated screw in the same way, and just with that you can change your trajectory and put in another screw. Remember, in the iliac view, the thing which you need to understand is you should not be going into the greater sciatic notch. You should remain above it by around 1 to 2 centimeters. And hence you will get, and in the through the wing view, you are ensuring that you are not going into the sacrum or the SI joint and going right up to the PSIS. And in the first view, which I said teardrop, that is where you are in the center of that osseous corridor, and hence you will be in the center. So this is the technical thing. I'll just show you how we, these were the books and the theoretical images which were taken from the references as I have quoted. And this is the way we do it. You see this iliac view, put in the screw or the drill bit above at the point where the AIIS is. You change the or manipulate the direction so you are going above the greater sciatic notch. You look at the inlet obturator view so that you are between the two corridors or through the wings of the ilium. You look at it and then put in your screw or the shank pin or the pedicular screw which you want. And if you want to look at the TP view, this pin has to be in the center of it. Subsequently, the same thing you can put in this and you can put in the screw, just showing you how you can do that. All the screws which are being put, the three views need to be taken: obturator outlet, obturator inlet, and the iliac view. And you can see how it has been fixed. Another case, just showing you the screw size does not matter. You can put in based on what you are trying to do. Since these were acetabular fractures, so the plates have already been put. So the screw is 3-5. You can also put 6-5, 7-5 screws in this, depending upon what your aim is and how much fixation you want. There are mechanical studies which show that if you put in 2 LC2 screws, which are around 6 mm or so, they are much more stable or equally stable than putting in 2 plates, one on the iliac crest on the top and one in the suprapectineal region. And this is the same 3 sequences, looking at the obturator inlet, the iliac, obturator inlet again, and putting in the top 2 thick screws. As you see here, we have put in a 7.5 mm screw going from right from the front towards the back up to the PSIS. So in the end, a fracture like this, which is an ideal case for putting in an LC2 screw, you depend and see whether you want to put in a reduction is going to be done open or percutaneous. And based on that, you fix it as here it has been done by an open, and this screw which is there is fixing your column, anterior column, fixing the pelvis from front to the back or from back to the front. Finally, since it's a technical note, just a pitfall you should remember, ensure that you are not going more medial to it, because if you are medial to the entry point and the TP view, you can damage the soft tissues, the vessels. The second thing to note is do not get into the greater sciatic notch and do not go into the SI joint. Sometimes your K-wire or the screw can go onto the outer wall of the ilium, and remember that out there the superior gluteal vessels are there. So if you are going on the outer wall also, you can damage a major vessel and cause a lot of bleeding. Sometimes your entry point gives a lateral cutaneous nerve of thigh, can be damaged by that. So be aware of that. Make sure that the 5 centimeters vertically down and 3 centimeters medially opening up with an artery, and then careful dissection up to the bone is done properly. And ensure that you are not damaging the tendon insertion or origin of the rectus femoris tendon. And sometimes there have been reports that people, while putting in percutaneous, have damaged the femoral nerve. So be aware of that. and look for those 4 images: obturator inlet, obturator outlet, iliac view, and the lateral view to know the full distance. Thank you.
Thank you, sir, for a marvelous presentation. It was really good to watch you there. I have really admired your LC2 screw video on YouTube as well. I think this one is just going to add to that one. Thank you so much for that.
Thank you. Thank you.
Nadeem, sir, any questions that you would like to add?
Do you need to, am I audible?
Yes, sir.
Yeah. Do you need to drill all the way to the back or just make a starting hole and then pass a screw from there?
So it depends. Normally, I normally put in my guide pin or a guide wire, which is there, and just over that I push in my screw.
But you're putting 3.5 screws, so you're not using calibrator.
No, it depends. Since if you see, it depends upon the fracture pattern and for what I am using it. If I am already putting in a plate on the iliac crest and the suprapectineal region, this is just an additional screw which is giving me the strength, which is augmenting my fixation. So there I normally go in for 3-5 screws because my plate would already be there and it might get obstruction. The screws might obstruct. If I'm going for a pelvis fixation where only this screw is going to be the main one with a pedicular screw, or for that matter, a thicker screw, then as I showed you, in a non-union case or in a case of pelvis, I use 7.5 or 8 mm screws. Sometimes you can put in even 2 screws out there. Since you are going into a big osseous corridor, which is fully cancellous region, and until and unless you come out of the posterior superior iliac spine, which you do not want to, because then when he's lying supine, it might get pressed. You normally do not require to drill it. The entry point is the only thing which you need to drill if required, if you're doing percutaneously. Otherwise, you can put in the screw. Remember, there is a narrow area around 10 centimeters from the anterior side and about 4 to 5 centimeters from the posterior side. If you are getting into that area and that area is very narrow between the two corridors, then putting in a thick screw, you might have trouble and you might come out in can happen in that.
Thank you. Any more questions?
Sir, sometimes we just get when we are contemplating anterior column screw as well. Then this LC2 screw, if you put a larger one, can sometimes go in the trajectory. Any tips to mitigate this problem?
Yeah, that's why you see that's a huge corridor of the supraacetabular corridor. In fact, the most of the screws which we put are into the middle portion of that. And if you want, you can also put in the screw in the supra portion or the most higher portion of that. You leave your lower portion because it has been around 2 inches, around 2 to 3 centimeters of corridor which you have. If you leave the lower 1 centimeter of that, from there you can easily put in a screw which is going in above the acetabulum into the pubic rami region. And your LC2 screws can be going slightly higher up at the level of anterior inferior iliac spine, which itself is around about 1.5 to 2 centimeters thick or lengthwise. So I would suggest that you put in a screw which is slightly up. Normally our screws, if you see, are going slightly up. If you tend to put in an ideal LC2 screw, it should be going around 1 centimeter above the greater sciatic notch, which is into the suprapectineal corridor. Whatever screws which we all are putting are usually putting that screw which is above the suprapectineal line and the area which is in the false pelvis. So we are invariably putting it slightly higher. The lower portion can be left for the anterior acetabular screws.
Can I add a small word here? Can I add a small word here?
Yeah, please.
Yeah. That inverted teardrop, if you divide it into 3 parts, upper third, middle third, lower third, don't enter the lower third part, leave it for your anterior column screw, enter into the upper third or the middle third, so that your trajectory of the guide wire will not come in the way.
So that's what the supraacetabular corridor, as I was saying, can be divided into 3 portions. There is a paper by a Chinese group which suggests that you can put in most of the screws in the supra portion or in the middle portion. The lower portion as such you don't want to put because your capsule of the hip joint is coming to at least 1.5 centimeters. So if you are tending to put in your screws of the LC2 screws lower down near the hip joint in an iliac view, remember that the patient can have a lot of pain out there, and that pain may not be because of the fracture. It may be because of your screw, which is going inside the capsule and causing him pain.
Can we go ahead? Thank you, Dr. Trikha.
Thank you.
Umesh bhai, are you ready to go? Are you ready to run your talk? Umesh bhai, can you hear me? Umesh bhai is struggling with his network.
Nicely explained, sir. Thank you, sir.
Umesh bhai.
Umesh was there, I think he was there. He just came online.
Umesh is seen, but I think he is not unmuted.
Excuse me, sir.
Okay. Parag, you had a question?
Yes, sir. Yes, sir. I have a question.
Go ahead.
Sir, hello.
Yes, shoot, go ahead.
Sir, I have just posted a X-ray or a CT pelvis of a patient which I recently operated.
Yeah, go on.
But the patient has a complete sacroiliac disruption with anterior column plus posterior wall plus sacral pubic diastasis. But whenever I went, when I already went from, my plan was that.
Hello, Dr. Umesh, any issues?
I think Umesh bhai is struggling. Maybe while he sorts his problem out. Parth bhai, while you finish your talk.
पेन का है इसका तो इसका पेन का है
हाँ सर आई एम रेडी
Yeah, please share.
Go ahead, shoot.
शेयर करूं यस आई shoot it I'll shoot hello good evening all of you
Good evening.
I will just start with the tough part can you see this can you see the my PPT can you see it
Yes.
Yes, sir. You go ahead.
huh
Yeah, please go ahead.
yes sir so should I make it full screen or it's fine
Yeah, no, full screen, sir.
yes.
Or go to the bottom corner. There you will find the screen, the image of the screen. Click on that.
Yeah, okay.
Is it okay sir can you see
Yes, sir.
okay sir now I'll have a tough case pediatric pelvis fracture so second slide
Parth bhai, run karo. हाँ.
okay sir I'm audible sir so pediatric fracture if we see we have one only 1 per 1,000 cases in pediatric fracture, you have pelvic fracture. The fracture has actually the mean age of 8 to 10 years. And when you have pedestrian injuries, more to lateral compression injury. And when you have occupants, it's basically APC injuries. So the fracture rare actually is only 1 per 1,000 cases. Okay, the physis which we fuse are different. These are very important for this. Initial tuberosity is 20-25 years. So all the apophysis like ASS, anterior inferior spine, 20-25 years. Crest, research science 20-25. But only the part which is important is acetabular cartilage, which actually united forward into 16 years, which is very important for fractures around at this area. So the key difference between the pediatric and adult pelvis are actually there is more flexible than because of thicker periosteum. They are more elastic at SI joints, and they have better hemostatic property because of small vasculature and less sclerotic vessels, and dampening efforts are better with thicker periosteum. The pathophysiology is they took a larger force to break up pelvis. They have more abdominal trauma first, then about this. They often stick and rings are more common injured than the cartilage. The clinical implication because they're high likelihood body, they have acid body region injury with the pelvic fractures. Acetabular fractures occur very rarely and contrary to our adult forms. The significant difference between abdominal and injury incidence. The remodeling potential vary. What we accept is not what we they are not well accepted as the age progresses. They lead to deformity of pelvis and leading chronic pain and gait issues. So you can see the mechanism of injury, the motor vehicle accident is 13%, which usually lead to APC, but the pedestrian struck by lateral injury, which cause lateral compression, is more commonly seen among all of them, the injury to the pediatric population. So risk factor basically are 10 to 12 years are more commonly injured. Motor vehicle accidents are very much common. When you have lateral compression injury, if thyroid catalyst is more easily injured, and is a high-speed injury which lead to these fractures. And acute injuries or head injuries are most common among them, with long bone injury and then viscera injuries like abdominal injuries. So the classification which we follow, it's a modified Tourette and Zig classification. Which is type 1, which is avulsion fracture of ASIS and anterior spine, axial tuberosity. Type 2 is iliac wing fracture. Type 3 is stable pelvic ring fracture, and type 3B is stable pelvic ring with anterior posterior injury, and type 4 is unstable pelvic ring disruption. And even we apply the same like Tiles classification for the same, and Ehrenberger's classification for the patient with the adolescent age. So we'll go detail with the modified Tourette and Zig classification. Type 1 is avulsion of anterior superior iliac spine and anterior inferior iliac spine and axial tuberosity. The apophysis avulsion fracture actually. Type 2 is basically iliac wing fracture. Type 3A is stable anterior ring fracture. Type 3B is pelvic anterior with posterior, and type 4, which is address more serious form of the injury, is unstable pelvic with both anterior posterior and might add acetabular fracture too. So as we do in all the pelvis injury, the first and foremost for all pediatric injury, first to resuscitate immediately. Check for ABC of that injury. Go for ultrasonography of the patient. Pelvic binder, obviously, it's must for every condition which we suspect for injury, and then we go for further survey. As patient gets stable, we can see for as an incontinence, blood at the urethra and a Faber test to see the SI joint more injury about the thing. And the same what we don't miss as a moral level lesion, which is very grievous injury, which they have sometimes it should not be missed, which lead to more complication otherwise. And always scuttle bruising and all that should be very well taken care of. Investigation, obviously the x-rays are the most easy and easily available. So but they're actually exposure to gonads are more concerned. So whenever it is there, only if you have find is clinically you find it's having a fracture, you just go for x-ray. Then comes CT scan. Whenever you have subtle SI disruption or fracture which are not visualized, you can go for CT scan so that you can see the basically posterior injury and acetabular fractures too. MRI is limited role when you have supple ligament initially, but that is only the key point is there is no radiation exposure to the patient. So when patient comes emergency department, the first thing is to do primary survey, apply pelvic binder whenever you suspect the injury. If you find there is no at high risk, you can remove the pelvic binder and examine as possible and go for X-ray if required. And if you high risk injury, you can go for fast. For example, lower limb discrepancy is more commonly seen in a pelvic injury, and you can go for CT abdomen pelvis and go for continue with pelvic binder. So there's a very important point that mostly 90% of the fracture of pediatric are mostly treated conservatively, and Morris type 1, 2, 3A, Tileway, APC1 and LC1, 2 mostly are a stable fracture which are treated conservatively. Now, what be important is how to follow up this conservative treatment fractures. It should be non-weight bearing for around 4 weeks. You have to get progressive X-ray at every 1 week, 2 weeks, so that it does not displace. When you find it at 4 weeks, or if you find it callus or form, you can start mobilizing the patient, and you keep on following the patient till it's adolescent. So you can see for any deformity, you can check it up, which differs from adult thing. So now operative indications are actually more to the type 3B with more than 2 cm displacement of the fracture lines close to the pubic symphysis. Type 4, which is addition of pelvis and acetabulum both. APC2, 3 and LC3 measure vertical shear, open fracture by itself, severe displace and polytrauma patient to mobilize it early. So now another question, whenever we have pediatric fracture, the first question, what implants will use? Actually, when your patient around 14-15 is with good height, weight, 3.5 routine implants are very well taken care of. But when you have smaller children, you can have 2.7s and mini plates available so that you can fix it. Screws are quite better than plate because screw removal is easy in this patients. So if possible, whenever it's possible, try to add a screw over it and partial thread screw to compress and remove to the fracture site, and so that removal easy. And even if sometimes if you have cancellous bone, you can negotiate a small 10 nail to the fracture, especially anterior column fractures. And if you are very small, you can go for only KR fixation. So what are complications? So you can see the more common complication is pelvic asymmetry, 9%. But patients with this have more psychological other on their feature. The hospital complication as usual is infection and neurological injury. Hemophilia is basically not needed in younger children. Pelvic asymmetry, which is pelvic and functional, is limb and discrepancy. 5% patient has limb and discrepancy even after conservative or operative functions. They have bad handlebar gait. The children functional outcome gains by 6 months and as depend on ossification center. Rest complication are urogenital, urethral, vaginal and kidneys injuries. So mortality rate are even from 1.5 to 16%, in which abbreviated injury scales 4 to 5 are more prone to get mortality rate than the ASI 3 and other. So the very important point of implant removal, which we don't consider in adult fracture, is pediatric pelvic fracture removal. In almost all cases, we require implant removal to be removed at least 6 to 12 months in this. And if the implants around thyroid cartilage, like anterior column or posterior column, should be removed as early as 3 months if you find a good callus on the X-ray. And percutaneous fixation, if you have long screws, compression of the fractures very well, you can remove at 12 to 16 weeks of the fixation, depending upon the formation of callus and clinical examination. So when to remove implant? First, you get once you get an X-ray and you check it up if there has a radiological union or not. You check for fascial involvement. If the fascia is involved with an implant, try to remove it early. If it's not, you can just delay it for some time. If you remove, you should remove not remove early also, then it might displace. And depending upon the callus formation and patient, you should remove the implant. But implant removal is usually by 3 to 6 months. So this is a case. This is a 14-year male hit by four-wheeler. So these are these X-ray. You can see the big fragment on the crescent area, which was very well explained by the previous speaker for removal of it. These are the CT scan. You can see there is a crescent fracture above, LC injury. The lower is oblique fracture of ramus. And you can see even the posterior column fracture is the lowest image. The posterior column fracture is displaced and is rotated internally, as you see routine posterior column fractures. So in this it was planned to take the big fragment which was preventing the reduction in the crescent was removed. This is the right fragment, which is this. You can see this fragment was preventing reduction, so it was removed from the from the, you can see even this pediatric, you have very big nerve root. You see L5 nerve root. So even with this pediatric patient, it is to be very good, should be taken care of. So in this patient, we took lateral window as usual for SI joint and crescent fracture. And in lateral, after fixation anterior pelvic injury, we turned the patient in the lateral position and went for modified Gibson approach to address the posterior column. So this was done one by one. So you can see the SI joint was made aligned. Instead of one screw was inserted on the medial side and one on the lateral side, just to get alignment of the sacroiliac joint. Then after getting alignment, I have inserted one K-wire on the S1 area under IITV guidance, passing through the S1 corridor. Then I've removed the lateral screw of the screw on the lateral side of the SI joint was removed, and got compression with the 6.5 cc screw. And after that, I've inserted the screw on the screw hole next to the previous one. So I got a good compression of the SI joint with the two screws on the medial, two screw lateral, one on the medial side. Then the iliac wing was fixed. And after that, you can see the modified Gibson approach was taken. And the fragment was actually totally displaced. So it was pulled with the hook, so it can reduce, but still I was not able to get the compression of the fracture side. So with the ball peg pusher, I push the fragment. Now I will get a very good reduction of the posterior column. So there were 2 points of friction. I should go with a screw and the lateral position, which would be made easily, but it was not difficult practically. So I opted for plate, and I have taken a modified Gibson approach and fixed with the plate with only 2 screws superiorly and only 3 screws distant, not a longer screw, because implant removal would be required after 3 to 6 months in this case. This is a post-op X-ray of the same patient. Another case, the 14-year female, which was rolled by Aisha while she was traveling to on a school on the bicycle. She had a bad anterior injury going up to the superficial CT scan. You can see the SI joint totally open up. Iliac bone is fractured, and even the anterior column is open, the dilated cartilage here. So again, the same principle. First, the SI joint lateral window was taken with iliofemoral approach. I think as osteotomy was done. The first two screw were inserted at the getting the SI alignment, just getting alignment, no compression. Then guide pin was inserted after alignment of the fracture sheet. You can see the gap is open. Guide pin was inserted like this, and the screw was compressed, and this screw was removed here. And then finally another 2 screw inserted. So after compression, I have neutralized with this plate, and another plate was applied superiorly. And then we have rode anterior antegrade column screw from posterior aspect to the anterior, and inserted a screw in this and compressed the dilated cartilage on the anterior column. And this is how we have got the reduction in all the views bypassing this joint. And this is the post-op X-rays of the patient. So my conclusion of the case is actually they're rare injury, 1 in 10,000, but they should be actually taken care of. The classification which followed is modified Tourette and Z classification, in which class most of them are conservative, 90%. Only type 4, which are to be operated with combined pelvis and accelerated fractures. They should be as taken as we do in the adult, like taking care of all the care of the acute injury. The routine pelvic X-rays recommended only if you find is hemodynamic and stable, and hemodynamic potential is more limited which we thought previously. So reduction of random reduction is very important in this fracture. Thank you.
Thank you, Parth bhai. I'm sure all of us have agree with you that these fractures are not very common, and it was very interesting to see your amazing stuff. What was really important and what was really worthwhile was the fact that you have to be very careful and to suspect these injuries. I think your observation is perfect, that bicycle versus car you've got in children happens very commonly these days. Children ride. Dr. Nadeem sir, is there anything else you would like to add, sir, to this?
No, not me. Ask Dr. If Dr. Vivek or Dr. Dinesh Kale would like to add something.
काले सर चले गए शायद.
Passing an SI screw is quite tough. Because the bone, the sacrum is really hard.
Yes,
Like
definitely, sir.
it's very hard to drill. I mean, not only hard to drill, to pass a screw also. That's what I've observed in 2 cases as compared to adults.
Right. So that's why I temporarily fixed with the plate and then I insert the K-wire and get the compression. Then I remove the screw and just get neutralizing principle like fixation.
Yeah.
It becomes easy to manipulate.
My experience is only of 2 cases. I have treated by hip spica another 3 kids, but passing a screw only 2 cases.
Yes. Well, I say more 90% are conservative only, sir. Only this are type 4, which are more displaced on the both the side, is to be fixed. And your point is very right. Inserting a guide pin is very difficult in this area in the pediatric patient. So I fixed temporarily with the plate anterior aspect, so it does not come in the way of my sacroiliac screw. And I insert the K-wire and remove the screw on the lateral side and fix it with the neutralizing principle.
A small trick I do is I use a thicker guide wire first
Right,
to
sir.
pass it, and
Right.
then remove that guide wire and
Yes.
pass a thinner guide wire for the. I don't use 6.5, I use 4.5 or maximum 5 mm screws.
Yeah.
तो
Yes,
उसका
sir.
guide wire thin रहता है तो, but to create a pathway, I use a thicker wire and replace it with a thinner wire.
Yes, yes. Just 2.5 wire and fix with replace with the narrow.
Yeah. Correct.
Yes, sir. But these both were 14 years female and male, so they were good heighted, and good body weights.
Yeah.
Yes, sir. One question, sir. Balakrishnan,
Huh?
sir. Is it possible to use a 6.5 screw in pediatrics, sir? Actually, SI joints.
Now
So I can't hear.
he is asking whether you can use the 6.5 screw. See,
Yes.
it all
Yes, sir.
depends on the structure of the patient. If
Yeah.
15, 16 is attaining nearly as adult, you can. But
Yes,
somebody
sir.
who
Yes,
is
sir.
below 8 to 9 years, probably 4.5 or 5 is more than enough.
Yeah, definitely.
Yes,
More
sir.
than
Yes, sir.
these both are around 14 years, 14 and 13 years male. They're good heighted. More height than me, sir.
Dr. Vivek would like to add
Yeah.
something.
Just to add to few things for pediatrics, as Parth has very rightly said, remember that the gap which you see in pelvic fractures or pelvic X-rays in a child will be much more than what you see in the normal adult because of the cartilage.
Right,
So
sir.
don't start considering anything and everything as fractures and displacements. That's
Very
number
true.
one. Number two, as he said rightly, 90% of them will be conservative. The same thing when you are actually fixing those fractures, don't try to get the imaging as an adult
Right,
because
sir.
these fractures are rare. So you try to over compress these fractures rather than getting the normal gap, because the gap will invariably be around 1 centimeter here, depending upon the age. But we are used to getting those imaging which are very small in the joint gap. So we tend to try to over compress and destroy the cartilage in them. And the third thing is, if you are putting, as he said, it was an adolescent patient, but many of those fractures, if they are in 7 to 8 or even young, just like in a femur fracture, you fix them with spica or with plaster first in early age group. Then you put in some K wires or TENS. So I have put in 2.5 K wires. I have put in 3 or Steinman pin for just 6 weeks to 8 weeks, leaving them and removing them just to maintain the position because they unite very fast. So don't try to be in a case of 3 weeks old, 4 weeks old, trying that I'll be able to create good things because it would have united, especially in crescent fractures. The pelvis posteriorly unites fast. These are the 3-4 things. Age-wise, you can put in screws. 4 mm screw, if you are putting in screws which are less than 6.5, try to avoid putting in cannulated screws in these patients. Put in a normal solid 3.5 or 4.5 screw, or even now you have the locking screws which are available. So I normally put in 1 or 2 locking screw heads. That gives me an adequate core of even a smaller diameter, and it is not, because if the bachcha jo hai, if he starts walking or something, when he, as soon as his pain, those things can break. So I normally tend to put in, if you're putting in a smaller screw, tend to put in a solid screw rather than cannulated. Thank you.
Yes, you are right,
Vivek
sir.
sir, one question, sir. One question, sir. Vivek sir.
Yes.
Go ahead.
Is there any epiphyseal problem, sir? Epiphyseal growth problem for the pediatrics, sir?
Yes.
Is
There
there
are
a problem?
there are growth factor problems if you fix, and that's why you tend to be least, you try to use as less metal as possible, try to just fix these fractures and with minimal invasion and keep them for some time, because the problem which you will have mostly is for the acetabular fractures in the triradiate cartilage area. That
Right,
is
sir.
the one which will cause you problems. The crescent
Thank you, sir.
ones, if you are able to get them closer together in the SI joint, more or less, unless the rotational problem is there, you will be okay.
Right, sir. True.
Dr. Vijay would like to add something.
Yes,
Dr.
sir.
Vijay Sharma.
Very good talk, Parth. I think very good collection of cases also. I had just one comment to make, like in both the cases, maybe you have done pretty more. So, like you applied a plate anteriorly, and then that is a very good trick. Like you remove the iliac part of screw and then compress the joint and then push the screw again. I think that is what you did. I
Yes, sir.
think
Yes.
that reduction plate, I think because like you said that most of these patients, they need implant removal after 3 to 6 months or maybe 6 months. So
Right.
removing a plate from SI joint is, you also know that L5 root is near and these are difficult removals. So
Right.
if that is just a reduction device, I think in you must have done in so many cases, like putting a displaced SI joint, you put a Farabaugh clamp, keep it reduced, and then put multiple screws across
Right,
the
sir.
SI joint. So just one suggestion, I think that would have
Taking off
been
the plate.
a better, because then there is no point of removal of that plate. Then later, then screws can be removed from the lateral. That's just a point to me. That's all.
Yes, sir. Definitely. We always have to keep in the mind while doing pediatric, you have to remove it.
Yes, sir.
So
Yes, yes.
what make it easy for you to remove? That's very important. Or use less plate, less implant, shorter screws than which you.
Because SI joint anterior plate, if you remove once, then you will never call the patient for removal. It is really difficult. Everything becomes sticky. And
Definitely.
then chances of, risk benefit ratio, chances of injuring patient is much more than,
Much
the
more.
benefit.
Definitely. Yes,
So
sir. We
that
can
is just
avoid
one
that.
suggestion. That is just one suggestion.
Yes, sir. Thank you, sir.
That's a really good suggestion. That's a really wonderful suggestion.
Wonderful. In pediatric patient, we can do this. Absolutely. Right.
We are almost at the 10 o'clock mark. Pradeep, shall we go ahead, or Umesh, are you ready with your talk or not yet? Umesh bhai?
I think my screen is visible now. Yes, sir. Am I audible?
Yeah, audible.
Hello.
Yes,
Yeah.
yes,
So
you're
I'm
audible. Go
going
ahead.
to share my screen.
Where we can't see your screen yet.
Yes, fine.
No, something seriously wrong with his network.
ये शेयर क्यों नहीं हो रही है?
Pradeep bhai, are you there? Dharmendra, are you ready to take your talk before Umesh? He seems to be struggling quite a bit. धर्मेंद्र भाई?
यस सर, गुड इवनिंग सर।
मेरे ख्याल से आपका ले लेते हैं, क्योंकि उमेश भाई का प्रॉब्लम हो रहा है शायद।
यस सर, मे आई शेयर सर?
Yes, go straight
Yeah,
ahead.
please.
Just start ahead.
So good evening, everyone. I'm here to discussing the recent literature on LC2 pelvic fracture. This is a very theoretical topic. I'm trying to, it is more interesting. So coming on to the introduction part. So LC2 fracture is considered a crescent fracture that is often required open adduction and internal fixation. But recent evidence suggests that LC2 fracture are not similar type because the instability varies in different type of same LC2 fracture, and the treatment should be based on morphology, instability, and reduction potential of the fragment. First controversy in the lateral compression injury is that every LC2 fracture are unstable. So historically, the LC2 injuries are considered rotationally unstable and vertically stable. But recent studies shows that degree and direction of instability varies significantly between patients. One paper published in 2022, they involved 2071 LC2 fracture, and they found that all LC2 injury are not uniform, and some patient had only internal rotation, while others shows cephaloid or posterior displacement. So suggesting that not every LC2 has the same instability. So how should we assess instability? So for X-ray is not able to assess the minor instability. So we can have a CT scan, which can evaluate the displacement of the fragment, how much SI joint involvement, and the associate. It will tell the associated anterior injury. In the selected cases, we can do the stress fluoroscopy that may reveal the hidden instability. So dynamic assessment is very important, but it is techniques not is fully standardized, and most research is needed. The question is not whether LC2 is unstable, but how much it is unstable and what how much instability needs to be taken surgically. So there is no universally accepted displacement threshold for surgery, and radiographic displacement does not always mean the functional instability. That is why dynamic assessment can be helpful. Another controversy is the crescent fracture, that is morphology. So according to declassification, we have three types: type 1, type 2, type 3, depending on the size of crescent fragment and involvement of the SI joint. So because why this is controversial? Because the fragment site doesn't decide the treatment, and for treatment to decide, we have to assess the CT scan to see the displacement of the fragment, see the rotation of the fragment and SI joint involvement, and available fixation corridor on the CT scan. So this classification is important, but it will tell only the fracture type, and CT scan is important to how to treat this type of fracture. One study published in 2025 shows that significant variability in crescent fracture, and day 2 was most common type, and treatment decision based on CT scan finding rather than classification in all.
स्क्रीन दबा दोगे और फिर व्हाट्सएप पे जाके वो फाइल कर देना तो सही.
And another controversy is who actually needs fixation. So traditionally, all LC2 fracture were treated with open reduction internal fixation. Nowadays, we have to get a CT scan so to see the to assess the displacement of the fragment, SI joint incongruity, and the to see the unstable anterior pelvic ring injury. And these components decide whether this fracture are need to fix or treated with conservative. So treatment is decided
Umesh, kindly mute yourself.
Based on instability, displacement, and patient functions. Another controversy is whether we need to fix the anterior fixation or not. So the study published in 2018 that they involved 19 patients of LC2 fracture. They show that more than 100 patients did not provide anterior fixation after posterior fixation. And another study published in 2024 that they show that anterior ring may contribute to significant to pelvic stability. So therefore, there is a controversy. So we should first determine whether fixation is needed and then which part is needed, whether posterior or anterior. So the sequence of fixation, the modern approach to stabilize first the posterior first and then reassess the pelvic stability and then decide the anterior fixation if necessary. Don't fix both rings automatically. Another controversy, open or percutaneous fixation. So traditionally the open reduction has been done for these fracture, but nowadays percutaneous fixation taken into place because it has a less blood loss and less soft tissue injury. And the paper published in 2025 shows that lesser morbidity as compared to the open reduction tendon fixation and achieve the same stability with less surgical trauma. Another case control study published in 2021 also shows that there is provider lesser hospital stay, lesser operative time, less blood loss, and provide the same stability and same comparable outcome with the open reduction internal fixation. There are newer reduction technique. Dr. Trikha has shown this paper in his presentation that this study published in 2025 by the Catrice and colleagues then describe the percutaneous fixation of this kind of LC2 fracture with the help of the science pin put in the iliac crest and then percutaneous fixation done. Another study published for the close reduction and percutaneous fixation in 2022. This shows that excellent and good reduction is achieved in the most of the cases with excellent functional outcome. So newer fixation concept in LC2 fracture. First is LC2 fracture, like Vivek Trikha has shown very efficiently, and then SI joint fixation plus LC2 fixation combined, and then another new concept is S2LR iliac screw plus LC2 construct. And this S2LR screw, this study published in 2005, then provide the posterior stability of the pelvic ring, and then LC2 screw provide the fixation of crescent fracture. They combined provide both stronger biomechanical stability, but clinical evidence is still limited. Another controversy is anterior posterior. So the study published in 2024, they found a similar functional outcome with the anterior and posterior approach. And posterior approach is achieve better reduction of the SI joint in day 1 and day 2 fracture classification. And when choosing the approach for this LC2 fracture, so most of the 1 and 2 injury are treated with posterior approach, and day 3 approach should be individualized. So there is a old and new concept for fixing and assessing this LC2 fracture. So old concept the LC2 fracture considered as unstable and required the open reduction tendon fixation with the plate. And nowadays, when we suspect LC2 fracture, we have a CT scan done, then to see the displacement and how much SI joint involved. Then we assess instability. If it is a reduced close, then we can do percutaneous reduction and fixation. If it is not reduced close, then open reduction and fixation of the LC2. Then reassess the anterior stability. If it is found unstable, then anterior fixation is done. This is newer concept, and take home messages of this presentation. Fracture, it has a different displacement and instability pattern, and CT scan morphology and stability guide the treatment, and reduction quality matters more than surgical approach, and management has evolved from open reduction internal fixation for the all to individualized fixation. We'd like to present some of cases done by us. So this is a type 2 LC2 fracture done in the open technique with a 2 plate. Here the interior ring is quite stable, so interior fixation is not done. Patient doing good, good radiological and functional outcome. Same here, same LC2 type fracture. So it was managed with posterior approach. Interior ring was quite stable, so not done interior fixation. This patient is also having good radiological and functional outcome. Another, this is type 3 fracture, C2 fracture. So and more anterior instability. So we have first fixed the interior with the recon plate done all across. Then we do the percutaneous fixation in type 3 LC2 fracture. Another type of LC2 fracture, this is also type 3 variant of LC2 fracture associated with acetabulum fracture and interior instability. So with the posterior approach, because the acetabulum involved posterior injury, this fragment was quite medium size. So we done prone position. We manage both acetabulum and iliac crest fragment from lateral position in posterior approach. Then in subsequent approach, interior fixation done in second setting. So patient is having good clinical radiological outcome. Thank you, sir.
Thank you, Dharmendra bhai. I think we can depend on you to show these amazing cases. I think you, Parth, Umesh, they do really amazing work. Great job. Nadeem sir, would you like to add something?
No, I would like to ask a question. Normally, it is said that you fix reduced anteriorly, but fix posteriorly first. In one of your cases, I think the third case or the fourth case, you fixed first with plates and then you fixed posteriorly.
Yes, because the posterior injury was not too much displaced. Type 3, day 3 type of injury, only a small size fragment of crescent and side joint is quite stable, means not much displaced. So that's why we did in last. And interior injury reduction also help in reducing the posterior injury in somehow.
Okay, thank you. Dr. Kale, Dr. Vijay Sharma, Dr. Pravin, would you like to add anything?
No, excellent presentation, Dharmendra. Good cases. Thank you.
Nothing from my side, sir.
I think we'll just let Umesh take over. I think the last talk for the day is by Umesh. Umesh, are you good to go?
Am I visible and audible?
Not yet.
Yes, you're audible very well now.
Yeah.
Just start sharing your screen.
Just now you are visible and audible. Why again you have gone away?
Actually, I am trying with mobile only.
Oh. You are visible. Don't worry.
Let's give him 5 minutes, sir.
Dr. Vivek, would you like to add anything in the meantime while Umesh gets connected?
Nothing, sir, not much. Everything is being covered in a very comprehensive manner out here.
Sir, I wanted to ask Trikha, sir. Can I ask?
Yeah, please.
Yeah.
Sir, while putting the LC2 screw, like I have often find it like using the obturator iliac inlet and obturator outlet view, getting the drill and along with the drill bit, pointing at the AIIS becomes very difficult because the C-arm directly comes over it. and putting the screw, drilling through the AIS becomes very difficult. So any tips and tricks for that? I hope my question is clear.
Yeah,
Like it
I
often
get you.
comes in the way.
No, I get you. I get you.
Getting adequate
Not a
space for putting that drill bit becomes very difficult. So I often turn up opening up minimally, putting 2 spikes on the inner and outer table and putting the drill. So my life becomes very easier and less need for 2 views.
So in fact, if you see the present literature, which even Dharmendra has quoted, and from where I took up my cases in the initial case, when I was
Yes, sir.
describing the technique, they have shown that, and if you saw my cases when I showed you how I am doing it, there was not
Yes.
a T. In my cases, there was not a single TP view in the initial times or in the initial part.
Yeah.
So the TP view or the obturator outlet view, which you normally tend to see, you can see it in the initial just to have an idea where exactly you want to go in.
Yeah.
And then you change over to the other 2 views, which we have told, which is the iliac and the obturator inlet. That gives
Okay,
you
sir.
a comprehensive and a complete view. And in fact, if you use them, and in the end, you will find invariably that you are inside the TP view in the center of that supraestabular corridor. Just
Okay, fine.
keeping those 2 views will be giving you the answers. Yes,
Yes,
if you
yes.
want
Thank you.
really, if you want, it's easy to see it in the end finally where you are, but otherwise those two views will suffice.
Thank you, sir. Thank you, sir.
Dr. Vivek, I have sometimes been using the Steffi awl rather than the drill, because if the drill is used to just open the cortex superiorly, the blunt gear stick kind of an awl also finds its own way and it's blunt. So it almost rare. I have never had a problem of penetrating the cortex. Have you
Yeah,
ever seen?
exactly. If actually this LC2 screw, normally
It just
you're not
walks in.
putting in. It's a corridor is very wide and very big with a full cancellous bone. And if you are in the right path, which is slightly lower down, then you will not be going into that narrow portion of the iliac tables, which will cause the problem. So it is said that if you want, you can just make an entry point with a drill and then take an awl, just like a pedicular screw.
Yeah.
You had the thing. The only thing is some of them are curved. So if you have a straight one, maybe that can
You
also
get
be
both, sir.
very
You get the
helpful.
straight one as well as the curved one, and both
Yes.
of them
Yeah.
are blunt. So they're blunt
Yes.
tips, so they almost never are able to penetrate the cortex.
Yeah,
And
they won't
you're
penetrate.
also able to direct it the way you want it. It allows a little fine adjustments, and never had a problem with that, sir.
Exactly. That's a huge corridor which we should be utilizing for our fixations, and that will help even for our pelvis acetabulum for any of those fractures.
Do you have any particular company, sir, that gives those long shank pins if you ever needed to put a supraacetabular pin in the same corridor?
So normally I would use the LRS pins, which are conical in shape, and that's what helps us, because I won't be putting in the normal shank pins which are there, because they are very small and their core diameter will be less.
Yes.
So I normally use the LRS pins which are there, conical one.
And is there any particular way to reduce the size of the tulip? The tulip for the pedicular screws for the infix is sometimes far too large, and
Yeah,
even if you decide
so
to take
that's
them out
why
later,
exactly, come what may, our subcutaneous fat in that region is somehow not
it's
that
not
big enough
limited.
to accommodate the tulips. So my indication for using an infix is relatively only in morbidly obese or patients with high BMI, because then only this infix can be very well tolerated by them. Otherwise, I was saying just few weeks back in one of the major conferences in South that it looks like a bucket handle, which the patient can has a cover over it, which is the skin. So infix many a times is like a bucket handle. So I tend not to put in the infix as an infix for people who are thin. I use it for patients who are obese as per the BMIs.
So thin with a suprapubic catheter, would you prefer the supraacetabular
Yeah,
X-fix
so I
as
know,
compared to
yeah,
the infix?
because Yeah, because of the fixation, because of the cost and economics. And if I just keep the supraacetabular fixator closer to the skin, we're not very wide apart from there, they're going to give me as good a fixation and stability as
Yeah,
is with the
probably.
infix. Infix is in Indian patients because I have a series of them, and we have in collaboration with other people in experience. It needs to be taken out within 3 to 6 months. That's for first thing. But in many of them, if you keep the tulip and if you use it in thinner patients, your tulip incision, the skin incision is going to give you problems. So if you're putting that, ensure that your incision is slightly away from the place where the tulip is going to come. That will help you somehow to make sure that it does not open up, the wound does not dehisce, and it's not infected very fast.
Would there be a case for nibbling out the AIISS little bit to allow the tulip to
No, because out here the question in infix, what happens is that it will happen for the spinopelvic fixation which you are doing from the posterior side. That if you nibble out your bone, it will help you for your reducing the prominence of the pedicular screws. But in an anterior infix, when you are using it, you need to ensure that your tulip and the rod, where exactly the rod is going to be, remains above the
same plane.
psoas muscle.
Yeah.
Because if you do not put in, so that's why the usage of or nibbling of the AIIS will not be much of any help, because the tulip anyway is going to be at the level of the psoas and at the top superficial anterior layer of your psoas. That's why. So you need to properly assess how many turns you need to go in, so that the tip of the tulip has got some 5 to 7 millimeters of subcutaneous fat over it, which is going to help you to keep it. Yes. So slightly bury it. Ensure that your rod of the infix which you are putting is straight out there rather than curved. You bend the tip of your rod. That way it will be easier, that you will not be putting pressure on the psoas, and henceforth you will not be putting pressure on the femoral nerve, which is a common complication of putting in an infix if you want to bury the tulip down.
Thank you, sir. Nadeem,
Nirbhay,
sir, I think
Nirbhay,
sir.
a small trick that I follow is,
sorry. Go ahead, sir.
Yeah. You take the TP view, just keep an owl pointed and hit the bone. Go to the iliac view, see that you are above the retrosciatic notch, and come back to the view which shows you both the corridors. Now you can centralize your owl, tap it, load your drill bit on a T-handle, don't load on a gun, and just go on turning it. It's a cancellous corridor. Your drill bit will go only in that pathway with no resistance. If you use a power drill, there are chances that your hand can deviate and you can puncture. I never drill with a power drill. I only load the drill bit on a T-handle and just go on rotating the T-handle. It takes the full path exactly in between the two corridors.
Umesh is off. I can't see him anymore. Do you think we should just
I think we should
take up his
conclude
talk
and
next time?
yeah, Dr.
Yes,
Nirbhay, please conclude, and we can have Dr. Umesh in the next webinar.
Sure. So it's almost about 10:30 now. So I thank all of you for joining us for this wonderful session. So much thanks to Dr. Nadeem to lead this way for this particular topic. Tough cases from Parth Bhai, Vivek sir, Dharmendra Bhai, Pravin. Always a pleasure to see you here again. I hope I've not missed out anyone. Sandeep, thank you so much for filling in for Pradeep. Pradeep is traveling, and so it's
No,
great
not
to
at
see
all,
you
sir.
here.
My pleasure. Yes.
And
thank you, Sandeep. Yeah,
thank you. If there's anyone else who would like to say something, otherwise you can just conclude and we can close the meeting here today. All good to go?
Yes, sir.
I'll stop the live streaming, sir. Thank you very much.
Thank you so much, sir. Thank you so much. Have a good night.
Thank you, sir. Thank you very much.
Thank you,
It's
sir.
very
Thank
useful.
you.
Thank you, sir. Thank you.
Good night. Where is Bala? Yaar, Bala, you've already taken off your shirt and everything.
Yes, sir. Yes, sir. Yes, sir.